Hey everybody, this is Dr. Medicine RX, and in today's video we'll be discussing about Gianotti-Crosti syndrome. It is also called as infantile papular acrodermatitis or as papulovesicular acral syndrome. So breaking down the name, infantile, it is seen in younger age groups. Papular, the type of lesions commonly seen are papular, and acrodermatitis because the lesions they are seen in the acral areas, or papulovesicular acral syndromes because the other kind of lesions that can be seen are the papulovesicles and they are commonly seen in the acral areas. So this is characterized by the occurrence of monomorphic symmetric papules or papulovesicles. Coming to epidemiology, it occurs worldwide and the most common age group affected is that between the 1 to 6 years of age. It can also occur in adults, but it is very rare. Coming to etiology, it commonly follows viral infections, and of these Epstein-Barr virus is the most common causative agent. Other viruses such as parvovirus, enterovirus, mumps virus, rotavirus, pox virus, HIV virus, and even hepatitis group of viruses can also be associated. Certain non-viral organisms such as Mycoplasma pneumoniae, beta hemolytic streptococci, Borrelia species can also be associated. It can also occur following immunization, and a history of atopy is frequently present in these cases. Coming to pathogenesis, it is not well understood. A variety of mechanisms have been proposed that it can be a viral infection as well as an immunological alteration, or that it can be a delayed type of hypersensitivity reaction to the viruses, or that it can be because of circulating viruses, or that it can be due to immune complex deposition. Basically, there is stimulation of the immune system by these viruses. Coming to clinical features, so 3 different varieties of lesions can be seen. These lesions, they are categorized into type A, type B and type C. So in type A, we see non-coalescing lesions which are symmetrical in distribution and they are small, round and pink. In type B, we see frequently coalescing lesions, and these lesions by coalescing form large edematous and pruritic lesions on the limbs. And in type C, we see frequently purpuric lesions. They have prominent symmetrical distribution, erythematous appearance, and they last for more than 2 months. Coming to other clinical features, so this rash, it has acute onset and it usually precedes, that is, it occurs before the onset of an upper respiratory tract infection or a GI infection, that is diarrhea. The constitutional symptoms are very minimal. They may not be present even. And this rash, it is characteristically pink or red in color. And the lesions, they are papules or papulovesicles, and the size, it ranges from 1 to 10 mm. Coming to distribution, so symmetrical distribution is seen on the extensor aspect of extremities and as well as the face and the buttocks. And this rash, it may have widespread involvement, but it spares the trunk, the palms and the soles. And there can be mild to moderate pruritus, and in about 1/3 of cases there is associated lymphadenopathy with cervical lymph nodes being commonly involved, and sometimes the axillary and the inguinal lymph nodes. There can also be hepatomegaly and splenomegaly, and following this onset we also see the features of the upper respiratory tract infection as well as diarrhea, nausea and vomiting. This rash, it usually disappears within 10 days, but it can last for up to several months. Coming to investigations, so if on complete blood picture we see leukocytosis with lymphocytosis and remarkable monocytosis, then it indicates that there is an active viral infection present. In cases of CMV and Epstein-Barr virus infections, we can also see abnormal liver enzymes, and in order to rule out or detect a hepatitis infection, we also need to do HBsAg, anti-hepatitis A antibody and anti-hepatitis C antibody tests. Skin biopsy, it is usually not required. However, it can be done, and we see features such as dense lymphocytic perivascular infiltrate of T cells and presence of dendritic cells in papillary dermis. These HPE features, they are not diagnostic, but if in cases of Epstein-Barr virus induced GCS, we can also see cytotoxic T lymphocytes. Coming to diagnostic criteria, positive clinical features, that is presence of typical rash, that is the monomorphous flat topped pink brown papules or papulovesicles of 1 to 10 mm in diameter, and at least 3 of the 4 characteristic sites, which include the cheeks, the buttocks, the extensor surfaces of forearms and or the extensor surfaces of legs are affected, and the rash is symmetrical in distribution and it lasts for at least 10 days, or the things that favor Gianotti-Crosti syndrome. The negative clinical features, that is presence of these features is usually not seen in GCS, which include extensive truncal lesions and presence of scaly lesions, or the negative criteria. Coming to treatment, so this rash, it is usually self-limiting. The syndrome is usually self-limiting and it heals without scarring. However, we can go for symptomatic therapy in the form of topical mild to moderate potent corticosteroids and oral antihistaminic agents and local antipruritics. There is no specific drug therapy. In refractory cases, we can go for systemic corticosteroid pulse therapy, and if there are any secondary infections, we can go for systemic antibiotics. Certain other differential diagnoses that should be considered while suspecting GCS include papillary urticaria, scabies, lichen planus, erythema multiforme, atopic dermatitis, pityriasis rosea, then lichen stridus, henoch-Schönlein purpura, and lichenoid dermatitis. Thank you. Subscribe for more.